At this point, we will move on to talk about treatment. Although treatment should be aimed at the underlying etiology of shock, the most critical aspect of treatment is prompt restoration of normal hemodynamics. Therefore, in terms of priorities, assessing ABCs is the most important. That is, ensuring the patient has an open airway, spontaneous respirations, and some degree of spontaneous circulation. The next priority is fluids and/or pressors. I've numbered them 2A and 2B here to denote that while they are on the same general tier of importance, fluids are usually more important in most patients, at least in the early course of treatment. The last priority is everything else, and by everything else I'm referring to things such as antibiotics and infections, PPIs and upper GI bleeds, and PCI and acute MI. I don't mean to de-emphasize the importance of these types of interventions. However, when prioritizing, you may have an hour to get the antibiotics in or to get the patient to the cath lab, while if they are in shock, you may have only minutes to improve the blood pressure before permanent organ dysfunction occurs or the patient arrests. So now, I'll talk about IV fluids. First, we can divide IV fluids into two categories based on whether they do or do not have a tendency to stay intravascular. With crystalloid fluids, only about 25% of it stays intravascular, while the other 75% either leaks out into the extracellular space or is taken up into the cells. Crystalloid fluids include normal saline and lactated ringers. Normal saline is a solution containing 154 milliequivalents of sodium and chloride per liter of water, very slightly hyperosmolar compared to blood. Lactated ringer solution is a relatively standardized mixture of sodium, chloride, lactate, potassium, and calcium. Crystalloid fluids need to be distinguished from colloid fluids, of which 50 to 75% stays intravascular. Colloid fluids include albumin, FFP, and a synthetic polysaccharide called hedistarch, which is also known by the brand name of Hespan. The greater tendency for colloids to stay intravascular is a consequence of the substantially higher molecular weight of its constituents. Between crystalloid and colloid is one type of IV fluid felt to be better than the other. Theoretically, because colloids stay intravascular, it would seem that they would be superior to crystalloids. However, every study ever published on the issue indicates they lead to identical outcomes, with the exception of some studies showing worse outcomes for synthetic polysaccharides in certain circumstances. Therefore, crystalloid is almost always the preferred choice, given its decreased cost and decreased risk from unnecessary blood transfusion or exposure to possible antigens. So if we should usually be using crystalloid, should we be using normal saline or lactated ringers? There is a common observation that internists tend to use normal saline while surgeons tend to use LR. But in most cases, it does not matter. However, there are just a few caveats to be aware of. First, normal saline can lead to a non-gap metabolic acidosis through a combination of several mechanisms. When this occurs, it usually implies that over-rigorous fluids have been continued in a patient who has been fully resuscitated. The metabolic acidosis itself is of no clinical consequence and resolves quickly once the fluids are scaled back. Next, LR is relatively contraindicated in acute renal failure due to the presence of small amounts of potassium, though this is also usually not clinically relevant. Also, the calcium in LR can bind to certain drugs and reduce their bioavailability if concurrently infused. The only commonly used drugs for which this is an issue are amphotericin and ampicillin. So now that we've decided that it usually doesn't matter whether we use NS or LR, how do we decide how much to give? First, IV fluids in shock should always be given in boluses rather than via maintenance fluids. Maintenance fluids replace fluids far too slowly and run the risk of overshooting if the patient is not being monitored very closely. How much fluids to give in your boluses depends mostly on the patient's cardiac function. If the cardiac function is preserved, 1 to 2 liters can be safely given at a time. If a patient has mild to moderate cardiac dysfunction, I would recommend scaling back the fluids to only 500 to 1,000 cc's at a time. If cardiac function is severe, such as an EF less than 25%, 250 cc's at a time might be more appropriate. Now, this isn't meant to suggest that patients with cardiac dysfunction won't necessarily need as much fluids as other patients, but rather there is greater risk of harm from overshooting in cardiac patients. Therefore, they may simply need more frequent smaller boluses rather than less frequent larger boluses for most patients. A patient in shock should be reassessed after every fluid bolus to determine if another bolus is appropriate. Now, how do you know when you're done resuscitating with fluids? Indications that volume status is adequate following treatment for shock include a MAP of greater than 60 to 65 millimeters of mercury, a CVP of 8 to 10 millimeters of mercury, a mixed venous O2 sat of greater than 70%, urine output greater than 30 cc's per hour or 0.5 cc's per kilogram per hour, normalized mental status, and normalized lactate. In providing boluses of fluid, it is hopefully apparent that we would like to maximize the speed at which boluses can be delivered. What is the best and worst venous access for this? The answer may be surprising. Here is a chart which provides a rough order. Remember that resistance to flow within a tube is proportional to the length of the tube and inversely proportional to the fourth power of the tube's radius. Therefore, the best access for IV fluids will be something that is wide and relatively short, like an introducer. An introducer is a very wide, single lumen catheter through which other catheters or devices can be introduced, such as a pulmonary artery catheter or temporary pacing wire. A liter of saline can be given in under a minute with adequate pressure. If an introducer is not immediately available, as it can be relatively time-consuming and risky to place, the next best alternative is 2 large-gauge peripheral IVs. Surprisingly to some, a routine triple lumen central line is only so-so for delivering fluids rapidly, as a consequence of each individual lumen having a very narrow caliber and the catheter's significant overall length. The absolute worst IV access for rapidly administering fluids is a standard PICC line, which can take over an hour for just 1 liter.